Well, welcome everybody to Optometric Education Consultants National Webinar Series, Sunday night edition. Tonight we're going to have a great retinal lecture to help everybody with retinal decision making. And our speaker is Dr. Julie Rodman, who got her optometry degree from the New England College of Optometry, and she completed a residency in hospital-based optometry at the VMC Brockport, West Roxbury, Massachusetts, VA. She has been a longtime faculty member at Nova Southeastern University's College of Optometry, where she holds the rank of full professor of optometry. She's longtime chief of the Broward Care Clinic in downtown Fort Lauderdale, and has been the recipient of numerous teaching awards. Her scholarly interests include retinal disease, optical coherence tomography, and angiography, and diseases of the vitreoretinal interface. And she is the author of a textbook entitled Optical Coherence Tomography Angiography, a Case Study Approach. So please, a warm virtual OEC welcome for Dr. Julie Rodman. Julie, you can take it away.
Thank you. Thank you, Joe. Thank you, Greg. It's fun to be with you guys. I'm honored for the invitation. So tonight I wanted to do this topic only because when I'm out lecturing, as I'm sure Joe and Greg hear all the time, I think one of the biggest things we struggle with as a profession is knowing when it's safe to hold on to something and when it's really not. So everything I say tonight, has been backed up by literature. That being said, there's probably always going to be room for controversy, but I will move through this presentation. Like Joe said, feel free to ask questions. Hopefully we'll be able to get to most of them. These are my disclosures. None of them are going to affect tonight's conversation. Everything's been mitigated. So I'm going to try to kind of present some case presentations, and then we'll go through some of the literature and talk a little bit about these cases. So this first one is a 58-year-old female who came in for a comprehensive diabetic eye exam. She reported that she had blurry vision in her right eye more than her left eye that didn't seem to go away. She was a type 2 diabetic of 10 years, and her fasting blood sugar was 188. A1C was 8. So remember that in our diabetic patients, we want their blood sugar definitely to be, somewhere in the 4 to 6 range. Even if we can get to 7, I'd be happy with that. So her A1C was a little bit elevated. She was diabetic, like I said, for 10 years. And we were worried about her right eye because that right eye was measuring 20/40. Her left eye was 20/20. So just a quick shout out to my friends at Eye Care who have been gracious enough to help to let us use their technology. This camera is called the DRS Plus, and I have to just say that the imaging has surpassed when I first started back in my residency. I think sometimes cameras do a better job than we do. But that being said, this was a photo of the patient's right eye, which was the eye in question. So take a minute to look at it. Remember that she's a diabetic patient. Remember that her visual acuity is 20/40 in this eye. So hopefully you can appreciate here that she has some hemorrhaging. She's got what looks like a chunk of exudate right here. And honestly, it doesn't look too terrible. A couple of little hemorrhages, microaneurysms throughout the posterior pole. So the diagnosis here is diabetic retinopathy. And really the question is, does she have diabetic macular edema? So I want to do a quick review here of the stages of diabetes. Then we're going to talk about referral patterns. So mild NPDR, we know, is defined as microaneurysms only. And something that consistently comes up in my retina class is, it's so difficult clinically to sometimes differentiate between a microaneurysm and a dot and blot hemorrhage. And I would argue that really the only way, if from a scientific perspective, is to get a fluorescein angiography. Microaneurysm is going to leak, whereas a hemorrhage, or microaneurysm is going to be white or hyperreflective, or a hemorrhage is not. And I think that that's really the only way. I think it's difficult clinically to make the decision. But when you're looking at a patient and you have, 1 or 2 little tiny spots, probably I would go with mild. Moderate falls somewhere between our mild and severe category, and we know that severe is categorized as the 4-2-1 rule. So I know this is basic, but just to kind of remember that if you have 4 quadrants of hemorrhages, 2 quadrants of venous beating, 1 quadrant of Irma, that puts us into the severe. So if you have something that kind of falls between that microaneurysms only and the 4-2-1, then we're in the moderate category. And then very severe is if you have 2 of the 4-2-1 rule. And then we all know what the proliferative is. We're looking for neovascularization. I'm not going to go into a ton of detail of the definitions here. I don't like to memorize, but there is also a high risk category. So when we go back to deciding on, referral patterns and what we can hold and what we need to refer, the first thing that I like to do is what everyone should be doing is grading the level of retinopathy. So when we look at this, we know that we definitely have more than microaneurysms. So we know that we're not in mild. And then we ask ourselves the question, do we have enough for severe? And I would argue that we don't. We certainly don't have 4 quadrants here of hemorrhages. So we're somewhere in that moderate category. And I'll also yell out or kind of just call attention to the fact that remember that when you grade diabetes, it's not as easy as saying mild, moderate, severe, even though that's what we're taught to do. It really falls along a number line. You guys have probably heard of numbers 43, 45, 47. The reason that there's numbers is because there's a lot of gray areas between these different definitions. So somebody could have, mildly moderate, somebody could have moderately severe. But I would say, just for keeping it simple here, this is a patient that has moderate NPDR. But we're not done there. After we've decided they have moderate, we have to always assess the macula. The macula is going to be super important because that's going to help us to figure out, is this the reason the patient has decreased vision? So in the good old days, and maybe perhaps still today, for practitioners that aren't practicing with OCT, we were taught to memorize or to learn this definition of clinically significant macular edema. And I'm going to be honest that if someone were to ask me right now to define these, I would be able to do it without this piece of paper because I personally don't use it in clinic because I believe in the OCT-based system. That being said, if you don't have one, certainly you should be familiar with these definitions. I don't know how Joe and Greg feel about this, but I find it so clinically challenging to sit behind, the slit lamp and start asking yourself, do I have one disc diameter within one disc diameter? To me, it's very difficult. So great thing. I think it's actually still being tested on boards, but I just don't love memorizing. So what I like to use is this. This is an OCT-based system to assess for diabetic macular edema. So we ask ourselves the question, first off, does the patient even have macular edema, which I'm going to show you in just a second how to figure that out. And then we're going to ask ourselves the question, is it non-center involving or NCI DME, or is it center involving or CI DME? And the definition really is based upon looking at a thickness map on OCT and evaluating the central 1 millimeter subfields on that thickness map. So let me show you an example of how that works, and then we'll talk about, again, referral patterns. So when you do an OCT, you always get a B scan. A B scan is what we're used to seeing. It's that horizontal kind of cross-sectional cut of the retina, which allows us to visualize for macular edema. We're looking for cystic spaces. We're looking for black spots on the OCT. So once you've established that the patient has macular edema, which is the first step, the second step is to always get a thickness map. This thickness map is essentially what we call an ETDRS map, so early treatment diabetic retinopathy study map, that breaks it down into quadrants. And we're looking at this center 1 millimeter quadrant. And basically, we're asking ourselves the question, is that 1 millimeter quadrant abnormal? And really, there's a lot of numbers in the literature that help us to kind of figure out if it's abnormal. I think the easiest thing to do is, even though I hate looking at colors, see what the normative database is based on the machine that you're using and see where that number falls. So center involving DME is when that center 1 millimeter subfield is abnormal. Non-center involving is when you're looking at it and you have an area outside of that this little area in the middle that's abnormal. So that will help you to determine how urgent the referral is going to be. So why does it matter? Again, eyes with central involved DME have a 10 times greater chance of developing moderate vision loss with center involvement than patients that don't have it. So I always ask the question, why do I care about this? Why am I teaching you this? Why am I telling you this? Because it actually does make a difference in the way that the patient's going to do ultimately, depending on where that macular edema is. So to make this a little bit clearer, you look at a patient, here's the fundus photo. Here's what we call the B scan. Okay, so remember the B scan is going to be this cross-sectional cut, allowing you to visualize anatomy. And then down here is our thickness map. So the steps that you're going to go through is you're first going to grade the retinopathy, which I'll go by, sorry. We decided this one was moderate. And then you're going to do the B scan. And you're going to determine, is there macular edema? So certainly we can see here that there are black, cystic or serous pockets of fluid on the OCT. There's also some exudation. So we've determined here that yes, there's macular edema. Do we know if it's CI or NCI DME just based on this? No. So the last step is to do this and to look at the thickness map. And here we've determined now that this patient has CI DME. So it's going to be, when you code it, you're going to write moderate NPDR with CI DME. So we know that this patient's vision was 20/40. So the question then is, how is that going to dictate what we're going to do with this patient? Just to show you an example here of NCI-DME, here's a patient again that has what I would say moderately severe, probably more moderate. I can't really see the nerve here. And then again, get your B scan. You can see that there is or are cystic spots of fluid here, or serous pockets of fluid. You get your map and you can see that the center 1 millimeter subfield is normal. So this patient has NCI-DME. So two patients with, let's say, moderate NPDR with different presentations at their macula. One more case here. This is, I would probably closer to severe. One more time, get your OCTB scan. You can see that there's definitely macular edema. Once again, get your thickness map, and this one is going to be CI-DME. So things to keep in mind when you have a diabetic patient. I want to specifically talk about the macular edema component of it. From a perspective of really any doctor that's taking care of diabetic patients, if you have diabetic macular edema, you should always consider referring. Okay, it's never, ever, ever wrong to refer. And the timeline should be within 2 to 4 weeks if the patient has CIDME. CIDME, we want to refer more urgently than we would if the patient had NCIDME. But there's a couple of things to keep in mind that I wanted to kind of just point out so you can stay ahead of the literature here. So when you're looking at, first off, NCI-DME, the guidelines actually tell us that if a patient has a non-center involving DME, retina specialists are not always going to treat. A lot of this has to do with the patient's visual acuity, with other things that are going on in the eye, with the status of the retinopathy. So always consider a referral, but it's also okay to observe these patients. And I would say that if you're going to observe them, I would follow them pretty closely, especially because things can happen pretty quickly. So maybe bring them back, within a couple of weeks, maybe start to spread it out if you see that things are not getting worse. The CIDME is even more interesting. We would think that, oh, if a patient has CIDME, we have to refer them. But the drcr.net, which is this group that keeps up on all these diabetic studies, came out with something called Protocol V. Excuse me. V stands for, I remember, very good visual acuity. So if a patient has 20/25 or better, meaning they have center involving DME, but they have good visual acuity, these patients are likely not going to be treated. Usually retina specialists are going to wait until vision is worse than 20/30. So these are patients that you certainly can refer, but the likelihood is that they're probably not going to be treated. So I would recommend probably co-managing these patients with retina, until they decide to pull the trigger and decide to treat. So just know what the visual acuity actually is very, very important when a retina specialist makes the decision to treat. So remember, if they have CIDME with bad visual acuity, then certainly we want to refer within 2 to 4 weeks, and they're likely going to get an anti-VEGF treatment. So the patient that I had moderate NPDR with, I think we said it was CIDME. So we're sending the patient out within 2 to 4 weeks for a referral, and we'll probably co-manage after treatment. So anti-VEGF drugs, just as a quick reminder, why I put this up here is we all know about the top ones, Eylea, Avastin, Lucentis. Brolucizumab's not being used very much, but I put this up here because the bottom one is fairly new, called faricimab. And I wanted to just throw this up so everyone's familiar with it. Faricimab is a new anti-VEGF medication that has, it's one molecule that has a dual mechanism of action. So essentially, when you think about an anti-VEGF agent or these agents on this page, except for faricimab, they work on VEGF-A. So the idea here is that by injecting this molecule into the eye, we're going to inhibit, the uptake of VEGF. We're going to inhibit neovascularization. So that's fantastic. So what does faricimab do differently? Faricimab also has what we call the anti-Ang2 FAB side, which works on erythropoietin or angiopoietin. And the idea here is that in patients that are diabetic, there's an uptick in this angiopoietin 2, which is not a good thing. So by preventing that alongside preventing VEGF, these patients tend to do better. They have longer duration between visits. So patients have been shown to go up to 4 months between treatments when using faricimab. The challenge that we have is always the insurance company, right? They're always going to try to use the less expensive molecules first. So I don't have very many patients that are on this, unfortunately, but it is a very efficacious drug, and I just wanted everybody to be aware of it.
Hey,
So
Julie, before you move on with that, or it looks like yeah, it looks like you have a polling question here. But I wanted everyone to realize that that was Vabismo that you were talking about there, right? I think that's what it is, Vabismo.
Mhm.
that's being talked about with that dual mechanism of action. So if you see it on TV or if you see it in your retinologist referring, that's what Julie was just referencing.
Thanks, Greg. So according to, let me just move this over so I can see my question. According to the AOA diabetes practice guidelines, which the following is appropriate management of a patient with DME. A, monitor annually with DFE and OCT. B, refer to a retina specialist within 4 to 6 months. C, monitor in 4 to 6 months with a DFE and OCT. Or D, refer to a retina specialist within 2 to 4 weeks.
What I should have done as a polling question too is how many people have more than one camera in their office. What I want to point out is that you did mention about having your camera system. I have two cameras. We do optomaps as screenings, but I can tell you that, not all cameras are created equal. I do have a camera, not claiming any superiority that's out there. I'm not claiming any bias that's out there with to try and keep it cope clean. But I do have an eye care camera also, and I have in some of my CE presentations where I have an Optomap and their camera system, and the optics are different, the way they take the picture are different, and some you might call mild, and all of a sudden you jump to severe based upon that grading category that you had that was out there. The polling question is open, just so people know, go to that button. And then while that's rolling in, I have one more comment about diabetes is that we always like to lump dot and blot hemorrhages together when we talk about diabetic retinopathy. Remember, I'll keep it short. A dot hemorrhage becomes a blot hemorrhage because the Mueller cells are dying. Mueller cells do not require a lot of energy. So if Mueller cells are dying and that dot is now becoming a blot, it is becoming very ischemic retina. And that's what happens in diabetes is ischemia. So if I see someone with 2 or 3 blot hemorrhages, that is pretty concerning to me because that's telling me that it's a retina that is more ischemic. All right, so let's display this answer. So no one went for A. We have 3% going for B. Oops, someone just went for A. So we have 2% for A. We have 3% for B, 12% C. The winner is 84% of D.
Very good. All right, we good to keep cooking here?
Sure.
All right. All right, so let's move on to the next case. This is a 6-year-old female who came in complaining of photopsia and mild metamorphopsia in her left eye. Her vision was 20/20 in her right eye, 20/50 in her left. And here is the photo. And, Greg, this is a perfect example of how this picture can pick up on things that when you're sitting behind this lamp, I mean, I would argue that, maybe this part of it would be easy to see, but I think that this part right here is hard. You can see that there's something superficial there, but maybe it didn't look stagnant when you're looking at it behind this lamp. So the photo really does a very nice job. So take a second and think to yourself, what possibly could this be? So I think the easy part is the shiny part here, which is an epiretinal membrane. And maybe if you had seen this person in the clinic, you would appreciate that this was actually vitreous that was still attached to the retina. So this patient had vitreomacular traction. And one of my favorite things to image with OCT are diseases of the vitreomacular interface. And I have quite a few slides here, quite a few cases, because there's always tons of questions about management decisions with these cases. So this is the first one. So I love this OCT. This is my Valentine's Day OCT. Here's my little heart. Okay. So this is a patient here that has a very thick epiretinal membrane, which you can see here, and you can see the vitreomacular traction. So we're going to go through some definitions here, but hopefully everybody can appreciate the difference between the inner limiting membrane, which is an extremely shiny, hyperreflective area, and an epiretinal membrane that lives really above the inner limiting membrane. So I like to think about epiretinal membranes as things that happen with anomalous PVD. So remember that as we age, our vitreous wants to detach. That's a normal age-related change. But when the vitreous doesn't detach, let's say in a timely fashion, or it's pulling too much, oftentimes it annoys the inner limiting membrane, the posterior hyaloid, which is this part here. It's the most posterior aspect of the vitreous. It's agitating that inner limiting membrane. So what begins to happen is you get proliferation of the glial cells, which make up the inner limiting membrane, and that is when you get epiretinal membrane formation. Vitreomacular traction, we know, is when the posterior hyaloid, which you can see right here, is not detaching cleanly in the process of PVD, and it takes some of the retina with it. The definition, if you were to ask, clinically, what is the definition of VMT? When you're looking at that central 3 mm areas right around the fovea and you see some abnormality in the foveal contour. So it's important to remember the difference between just having an anomalous PVD, meaning, you can see that there is some vitreous attached, but it's not changing the anatomy, versus vitreomacular traction, where you actually can see that there's an anatomical change. And usually we see ERM and VMT happening in the same eye. Something to keep in mind with ERMs is the older we get, the more at risk we are of developing these, mostly because we get PVD as we age. So if you look at the statistics, being older than 50, there's about a 2% chance of having ERM. And then older than 75, that is 10 times greater, 20%. So that's, I guess we all want to live to get old, but everything seems to get worse. And in about 10 to 20% of cases, ERMs will be bilateral. All
Hey,
right,
Julie,
so
go back one slide, if you
one more.
can. Yep, to that one where you had I think your heart shape right there. You can
Oh,
stop
one
right
more.
there. We always talk about yep, right there. We always talk about the 3 mm, and we always talk these numbers. And you and I, we teach this, we do it, and so on and so forth. What I want to point out is that bottom scan down there. Is that a 6 mm scan in a sense? Would that be about a 6 mm cut?
Yes.
Yeah. So just so the audience would know that from where that foveal pit is, going 3 mm one way and 3 mm the other way. So when you see this kind of cut on your OCT, that's your typical 6 mm, and that's all macular. Remember, the macula is 5.5 millimeters. So that's your whole macula that you're seeing. You see the foveal pit. Here you're seeing the vitreomacular traction. So when she talks about to the center 3 mm of the fovea, you can kind of gauge where that is in the 6 mm cut.
It's a great point. And just
Perfect.
going back one more, something that Greg brought up that I didn't discuss here, something to keep in mind, because I'm going to talk about this in management in just a minute. When you have a patient that has vitreomacular traction, epiretinal membrane, remember that visual acuity could still be 20/20. The thing that really dictates what the patient's vision is going to be is when you look at the integrity of what we call the photoreceptor integrity line, also called ISOS junction, ellipsoid zone. We're looking at this hyperreflective line here that lives right above the RPE. So when you look at it right in the center, right at the fovea here, if this area or this line is broken in any way, patient by definition really is not going to be a good 20/20. Even this patient, you can see that it looks a little bit hazy here. So I would argue that this patient probably still has very good vision. Is it 20/20? Probably not. It might be 20/25. But really, it's important to look at the integrity of the PIL. In fact, when patients go and have procedures done, if you have a broken PIL before the procedure, your outcome is obviously not going to be as good as if it's intact.
It's not in the literature yet, Julie, and and you haven't come across it yet, but that line has another name for it. We call it the Caldwell line. And the reason why is that it's coming out in the literature here very shortly, is that I was trying to figure out why that was important. And then two, why did it hyperfluoresce? And when you look at that anatomy, we all know that the outer retina there is basically the photoreceptors. Above it is the myoid zone. Below that is the ellipsoid zone. But the ellipsoid zone, that's the mitochondria, the way they line up, and they're so tightly packed. There's about, I don't know, 300 or 400 per photoreceptor. They're so tightly packed that the coherent light makes them light up. So not only, you're correct and 100% correct that that can dictate the acuity, that ellipsoid zone, the PIL, but I want people to realize that that is the mitochondria, the photoreceptors, and we see all kinds of oxidative stress from that whenever we see macular degeneration. So it's the mitochondria of the photoreceptors, soon to be called the Caldwell line.
Is that really true, Greg?
No, I just make that up. So,
Okay.
but
All
the
right.
other,
So
all the other stuff was true though.
all the other stuff is true. So when we think about this from, do I need to refer? Well, I like to say if you want to stay excited about seeing patients, you want to stay excited about optometry, don't refer every single thing out. You always can, but know when it's appropriate to hold on to something. So if you have a patient that has an epiretinal membrane or has VMT that's asymptomatic and vision's good, you can watch them. You know, this isn't the kind of thing that we need to be sending every single thing out. So if you look at the standard of care here based on the AOA and AAO guidelines, if you have an early stage asymptomatic epiretinal membrane and or VMT, monitor them. You can decide if you want to see them back in 2 months, 3 months, 4 months. Look at the status of the other eye. If the patient has a history of having poor outcomes, especially in the other eye, you may decide that you want to see them sooner. The other thing to keep in mind is that there are different types of vitreomacular traction. There's focal VMT, which essentially means that from point A to point B of the attachment of the posterior hyaloid, it measures about 1,500 microns or less, versus something that's broad, like this picture, where it's greater than 1,500 microns. Those have different prognoses. So a focal VMT tends to have a worse prognosis than a broad, because if you think about pulling something very, very strongly in one very well demarcated area, you're more likely to get a macular hole versus if you were to stretch out that pulling across a larger area. So keep in mind, you know, what you're dealing with. Did you just happen to find it on exam, or did the patient come in with symptoms? Now, if the patient is symptomatic, meaning they have a decrease in visual acuity, which there's a lot of range in the literature, but 20/40, 20/50-ish, if they have metamorphopsia, if they have diplopia, if they can't fuse, those are certainly patients that would warrant, or we owe it to them to refer them to the retina specialist for a possible vitrectomy with membrane peel. Though that surgery, when done properly, does a very good job. Patients tend to do very well. Approximately 80% of these patients are going to improve by at least 2 lines following surgery. So keep these things in mind. I think the summary as we move through this presentation is that whenever a patient is symptomatic, I think you owe it to them. In fact, you should refer them for a retina consult. So the clinical pearl here is that the majority of epiretinal membranes are going to remain stable and not require treatment. Patients who have areas of VMT that are focal have about a 33% incidence of spontaneous recovery, meaning that the traction will just release and the patient will do well in about 1 to 2 years. So it's okay to observe. What I would again say is if you see any signs that things are worsening, if visual acuity is worsening and there's no other reason for it, if you start to see that the photoreceptor integrity line is becoming compromised, certainly refer the patient. Don't sit on it.
Hey, Julie, let me just point out that you know, the camera system that I have has what's called flicker ability, where you're able to take if you took it 2 days apart or probably the same day, you can actually just take it and it lines all the blood vessels up and it does alignment and flickers them back and forth. And from what I've seen is that epiretinal membranes are more alive than we think with fundus photography. I have one, if I remember, I'll send it to you tomorrow. They just came in last week and it's a great amount of change. And there's this slight change on the OCT, but you're able to see, the numbers are changing on the OCT. It might not seem as dramatic on the OCT, but when you look at the epiretinal membrane and you flicker it, you can see the blood vessels changing. You can see the retina distorting. It's kind of cool. So as you always talk about multimodal imaging, photography and FAF, fundus autofluorescence, and OCT. This is one here that I'm starting to realize that these epiretinal membranes are more alive than we think, and that was brought about by this flicker photography.
Yeah, that's a great point. And, you know, Greg, on that point, you know, if you go back to this photo of this OCT, you know, people don't think about this, but there's actually 2 different types of epiretinal membranes. People don't really usually categorize them, but when you look at an epiretinal membrane and the blood vessels are unaffected and you just see this glistening, we call that a grade 1. Once the epiretinal membrane begins to, like Greg said, take the vessels with them or start to become more fibrotic, then those are called grade 2. So there are a lot of things that you can see with epiretinal membranes. In fact, this one right here is a really nice example of how these retinal blood vessels here are beginning to kind of get pulled by the epiretinal membrane. So this is obviously more significant than the patient that we had before. So on that, this is a 67-year-old who's symptomatic. He's 20/70. He's seeing shadows, he's seeing doubling of images, and he says it started yesterday, you know, which we know probably is not the case, but maybe it just has, you know, been brought to his attention. But here you can see that the blood vessels are definitely starting to change what we call trajectory. Whether you use the flicker function or just look at this, you know, naturally, you can see here that there's definitely a lot of activity there, that this membrane is definitely pulling. Here's some really nice different representations, OCTs. This is just the regular B scan here, where you can see that there's this thickening. You can see that the retina certainly was pulled by this epiretinal membrane. This is a nice in-depth look at just that thickening that's happening. And then this is an en-face, or like an angiography image. There's these slabs where you can see the vasculature being pulled by that epiretinal membrane. I always think that's really cool. So, when you look at this OCT, which is not true, there certainly is an epiretinal membrane. There certainly is foveal thickening from traction. Is there widening of the OPL? Yes. Is there a full thickness macular hole, which I think that we can all tell that there's no break in the retina here at all. So that one is incorrect. So for this patient, when you think about, do I need to refer them? Do I not need to refer them? Think about, again, what's the vision? He's 20/70. He came in symptomatic. This is a no-brainer, right? We're not going to sit on this one. We're going to send this out. Hopefully this patient will get some intervention. I wanted to share this video just of an epiretinal membrane peel here. We talk a lot about vitrectomy with ARM peels, and I always feel like these videos are always very useful. So let's give it a whirl here. So you can see the fine hand that's needed to do that. But I always think that's incredible how they go in there and they just lift it up like a piece of saran wrap. So, and just another image here of a beautiful epiretinal membrane. You can see here the tractional bands, and this just like almost looks like a little egg in the middle here. So just a really nice, another nice example of an ERM there. Sorry, let me get back down here. So remember, when you're thinking about, do I need to refer, do I not need to refer, ask yourself these questions. Is the patient symptomatic? And always ask about or check visual acuity. This is something that actually was a patient that was at our clinic. It was a patient that we were following for many years with an epiretinal membrane and was not referred out. I don't know the specifics if the patient had good visual acuity. If they didn't, regardless, the patient was never sent out. They came back to us about, I want to say 7 or 8 years after initial diagnosis of an epiretinal membrane. And hopefully, if you're watching this at home, which you are, you're thinking to yourself, what the heck happened there? What came first, the chicken, the egg? Who knows? Well, I can talk you through what we believed happened. This patient had this large epiretinal membrane. The epiretinal membrane caused traction and distortion and problems to the surface of the retina, resulting in a macular hole. So this is a macular hole. What happens when you have a macular hole? Well, fluid can enter into that space because you have a full thickness break between the ILM and the RP. And this turned into a little retinal detachment right here. You can see there is a elevated area here extending right off of the macular hole. So this patient did not have a great outcome. So this is what you don't want to happen in a patient that has an epiretinal membrane that, perhaps still has traction on it, which is allowing that macular hole to form. Here's the OCT just kind of showing you how there was a full thickness macular hole and the patient went on to develop a retinal detachment. So I think we're in our next poll question here.
Yeah, I pulled the trigger on it pretty quick. I thought that was your polling question earlier. And so it's been open and people have answered. We have B, 91%. Everyone else is at 3% for A, C, and D. So your asymptomatic patients are
perfect.
ones that you do not need to refer.
Okay. All right, let's keep moving along here. So this next one is a 45-year-old male. He's asymptomatic, 20/20 in both eyes. So again, more diseases of the vitreomacular interface here. Take a good look at it. See if you can appreciate what's happening here. So I'll kind of walk through. If you can see, there's some tractional lines here. And then it looks like what looks like a little maroon spot there right at the fovea. I don't know why that's not working. Okay, so this patient had a pseudohole with an epiretinal membrane. And you might be asking yourself, how did I know that it was a pseudohole? How did I know what the diagnosis was? So another place where OCT certainly shines, right? When you look at a macula, you look at a retina, and you just want more information, get that OCT. And I'll show you in just a minute what it looked like. But a macular pseudohole is essentially a type of partial thickness hole. So they tend to take on a U shape. They're usually related to an epiretinal membrane, but they don't necessarily have to be. The important thing to keep in mind is that when you have a partial thickness hole, you don't have a complete break through RPE. You're going to notice that there's residual tissue living somewhere in the sensory retina. It may look like a full thickness macular hole. One of the things that may help the diagnosis if you don't have an OCT is vision, right? Visual acuity in a full thickness macular hole is going to be much more significantly affected than in a patient that has a partial thickness macular hole. So this is what an OCT on top of a pseudo hole would look like. This is going to be a full thickness hole. Remember, complete loss from ILM down to RPE. The pseudo hole has like this little U, this little cup here, but look over here. There's still residual tissue living here. So important to ask yourself the question once you've made the diagnosis, what do I do with this patient? But before we get to that, let me talk about the other kind of partial thickness hole, which is called a lamellar hole. So pseudo holes are one type of hole that usually take on that U-shape appearance. Lamellar holes are the other kind of partial thickness holes. And lamellar holes come in two varieties. The first one is called tractional. Tractional tend to take on a mustache-like appearance. So when you look at it, the first thing to ask yourself is, do I see a full thickness break? Because there's still tissue here, we know that this is not full thickness. It doesn't really look like a U shape, so I wouldn't call it a pseudo hole. What you will notice is that there's an epiretinal membrane, pretty thick one right up here. And then you'll notice what we call a foveal schisis. A foveal schisis is where you see splitting with these pillars forming this mustache shape coming in both directions. Some people like to call it an anvil shape, like the tool. So this one is tractional, particularly because it's associated with an epiretinal membrane. So that's the first type of lamellar hole. The second type is called degenerative. Degenerative tend to look like a top hat. They have rounded edges, and they have something called epiretinal proliferation, which is not an epiretinal membrane. It does not have a tractional component to it. So when you see these kind of rounded edges like this, and remember, there's still tissue here, so it's not full thickness, and you see this lip here, that tends to go along more with the degenerative type of lamellar hole. So really three different things: pseudo hole, lamellar tractional, lamellar degenerative.
Julie,
And
can you go back one slide to your tractional?
yeah.
Because I think it's great to point out, and this kind of goes back to maybe your diabetes. If you, on the left side there, if you want to use your pointer, is that there's a loose association between the inner and outer retina. And that's why when the inner retina, where the blood vessels are in diabetes, and what Julie pointed out before, and when they're leaking, diabetes is a capillary disease, and that exudate and fluid leaks out, it goes to that. Remember, the inner retina is tightly packed. We're able to see the photoreceptors there beautifully. And then there's a loose space in there. And that's why that kind of tractional will pull across that, that inner and outer retina. There's that loose space in there. And again, that's where diabetes fluid will form, so on and so forth. So just kind of remember there's two layers in a sense, kind of all the neurological wiring and the photoreceptors. And again, I'll say it a third or fourth time
Yeah.
in that loose space, but you can see it there. And then as you go forward, you'll see where the other that loose space is. And that's why that can kind of easily separate.
Yeah, and that kind of talks, when we differentiate between something like central serous versus a PED, right? Central serous, you're going to see a lot of separation, a lot of looseness within the tissue because you're in the sensory retina. When you have a PED, you're going to have that very tight, sharp cut because you're dealing with a very tight, the blood retinal barrier there. So excellent point. So here's just a really nice picture of a degenerative lamellar hole. Remember, those little white carrots are pointing to that epiretinal proliferation, which we call isoreflective because it has the same reflectivity as the tissue underneath it. It is not tractional in nature. And notice how you have the rounded edges. So degenerative lamellar, remember there's tissue here, so this is not full thickness. So just a quick quiz here. I think this is going to be easy. which is which. A is going to be the degenerative, B is going to be the tractional. Remember to look for the rounded edges, the epiretinal proliferation. Look for the epiretinal membrane here. Look for the foveal schisis when you're talking about tractional. Okay, so hopefully, I don't know why I'm sorry, that's not working. So just remember to keep those both in mind. So if you want to be able to categorize them better. Now, here's the question. If the patient came in, which I presented there, he had an epiretinal membrane, he had a pseudo-hole, what is the management? So first and foremost, if the patient's asymptomatic, you can always, depending on acuity and all that good stuff, you don't necessarily have to refer. So here's a couple of reasons why you might want to refer a partial thickness hole. If the patient has functional or anatomical deterioration. So once again, is their photoreceptor integrity line compromised? Does the patient have decreased visual acuity? Do they have metamorphopsia? Again, do they have poor entering visual acuity, resulting in inability to perform daily tasks? Listen to the patient, ask the patient what their symptoms are, and then also use your own skills to look at the OCT to understand what you're seeing. Other guidelines against surgical intervention if vision is less than 20/40, same idea that we talked about with epiretinal membranes and vitreomacular traction. They might go in there and do an ILM peel with vitrectomy. There's also a fairly new procedure called an ILM inverted flap, which I'm going to show you a video of. It's really cool. And I don't know, that it's being used extremely often, but it is something that has been shown efficacious for these partial thickness holes. So something to keep in mind, but just understand when you can hold and when you can refer here. And always, if you're unsure, you should refer. This last one is also a really key point here. Preoperative defects in the PIL, which we talked about before, are associated with worse visual prognosis. So if you go back to this previous OCT that I just showed you over here, this big one, look at the PIL here. This patient's PIL is certainly not perfectly healthy, right? There's some breaks here. There's some areas where you see that it's not as strong and as it looks over here. So even if they went in and did something, let's say this patient was 20/60 or 20/70, having that compromised PIL is certainly going to have an effect on the outcome ultimately when the patient's done with surgery. So I think the video, yeah, here we go. So let's show this is the inverted ILM flap, which they do for partial. This is going to be a full thickness.
Julie, while this video is going, the other thing I'd like to point out with an epiretinal membrane is epiretinal membranes are kind of slimy whenever they're and as we see here, surgeons like for them to be more mature. So, they have to be a certain size. That's probably why they grade them, because if it's kind of like, I kind of think of it as Jello. If you get Jello and you just make it and you put it in the refrigerator and you try and grab it, it goes right through. But if it let it kind of solidify, you can grab it with a fork and it doesn't fall through. So certain surgeons might sit on them a little bit to let them mature so that they can peel them like they're doing here.
So what they're doing is they're taking that ERM and they're stuffing it actually into the hole, which I think is super cool. Instead of just removing it, they're actually taking the tissue and,
there you go. Yep.
pushing it in there, which is really neat. And they're going to show you the post-surgical OCT, which is super, it's really neat. So a really nice outcome there. And you can see that the PIL is still compromised. The vision's not going to be perfect, but at least the patient doesn't have the break that they had before. So, and this was a full thickness, so they had a really good outcome. Okay. Sorry, let me go back here. All right, we're going to switch gears here, come off vitreomacular disease for a little bit. We're going to go back to that in a little bit, but this was a 73-year-old white male who came in for a comp. His chief complaint was difficulty seeing at night. And I just want to emphasize here that we all know that when our elderly patients come in complaining of difficulty at night, the first thing we always think of is cataracts. And I kind of want to change maybe your thought process tonight when you hear this complaint to start thinking outside the box a little bit. This is going to be an AMD case, and one of the biggest things we see with AMD, one of the earliest clinical or one of the earliest chief complaints that these patients have is actually difficulty seeing at night. Social history: he was a smoker for 40 years. He still smokes. He has a positive family history of AMD, and he's 20/40 in his right and 20/20 in his left. And we're going to talk a little bit about AMD because the guidelines for management and referral have changed quite a bit in the last year. So when you look at this patient, this was a patient that, again, it was 20/30 in his right or 20/40 in his right, 20/20 in his left. And I want to kind of call out and say that I totally missed the ball in this case. And I like to share these cases with my colleagues so that you guys don't make maybe the same mistake and it just didn't turn out to a big mistake because I use multimodal imaging to find the diagnosis, but just to kind of lead you in that direction. So I'm going to start off with the right eye and go through how we categorize and what the management pattern should be. So when you look at this patient, you can certainly see that they have drusen of various sizes, small drusen, medium drusen. And I want to go through this categorization system here just to reemphasize the importance of proper categorization. So the first category, and you're probably wondering why, is no apparent aging changes. Why do we need a category that tells me my patient doesn't have AMD? And really the reason is that when you are seeing elderly patients, or really any patient, some patients just present with one or two tiny drusen at the macula. And I think it's important that we don't give everybody a diagnosis of AMD. So if you see a patient that has a really, really tiny little kind of salt, the size of salt, don't tell them they have AMD. That being said, when we get into the early stages of AMD, we're looking at the size of drusen, okay? And some people think, and I agree, it seems ridiculous to sit and start measuring drusen in the clinic. But if a patient has medium drusen, meaning they're less than 125 microns and they don't have pigmentary changes, then we can call them early AMD. The important category is when we start getting into the intermediate stages. And intermediate AMD is when you have at least one drusen that's 125 microns or larger. So when you ask yourself, what does that mean from a clinical perspective? What am I looking at? If you look at the size of the central retinal vein as it leaves the optic nerve head, the diameter of the vein is around 125 microns. So if you look at that and use that as a clue, if you have a drusen that's about that size, you're into that intermediate stage of AMD. The other thing that you can look for are pigmentary changes. Once the pigment becomes dispersed off of the RPE, we know that the RP is sick and it's becoming atrophic. So we're going to talk a lot about the intermediate stage in just a minute because it's a super important stage. But looking back at my patient here, where does he fall? He probably falls somewhere in the early to intermediate stage. I would say that maybe this drusen's getting into the intermediate, but I would probably still call this early. And again, does it matter so much at this point? No, but it's important that you understand what you're seeing and what would push this patient over. And then we know what the late stages or the advanced stages are when we have either a choroidal neovascular membrane or geographic atrophy. So looking at this patient's OCTs, there's something called reticular pseudodrusen. Remember that a regular drusen, as we see on the bottom here, is a spot that lives between the RPE and Bruch's membrane. When you have a reticular pseudodrusen, these drusen tend to go into the subretinal space. So they break through the RPE and they actually extend up into the right above the photoreceptor. So reticular pseudodrusen are actually correlated with a much more advanced rate of progression, and patients tend to be younger when they get them as well. So if you have an OCT and you see these reticular pseudodrusen, keep in mind that these patients are likely going to progress at a faster rate. That being said, this patient probably is in the early-ish / intermediate stage. I would still probably call it early at this point. 2 years later, I see the guy back and he's got this spot, which I'm pointing to with the green arrow because I thought, at this point, I actually knew what was going on because I'll show you in a minute the other eye, but could it be a drusen? What could that be? This patient actually developed geographic atrophy in that spot in a 2-year period of time. His vision went from 20/20 to 20/40. And I'm going to show you throughout this case, multimodal imaging, but the importance of how we can change our management patterns. So if the patient, I'm not talking about what happens to him, but if you had a patient that presented with an intermediate AMD, in the good old days, what did we do for them? Well, we said to them, do all this stuff: diet, exercise, cardiovascular health, don't smoke, take an AREDS vitamin. But we have some great stuff now that are right at our fingertips to help our patients. things that can also help us as practitioners. I wanted to talk a little bit about home monitoring and artificial intelligence, particularly in patients that have intermediate AMD. This is an amazing, I want to say, advancement, particularly for age-related macular degeneration, because these are patients that sometimes it's hard for them to get into the office. Sometimes they don't know if their disease is getting worse. So if you have a patient that's intermediate and they're converting, a lot of times they don't know that they are. Maybe they're relying on one eye. So these are really great tools that patients can use in the comfort of their own home and can actually help us as practitioners take better care of our patients. So there's two devices that are made by No Television. One of them is the 4C home monitoring program, which is actually used for patients that have intermediate AMD. So what it is it's this little device that the company sends to the patient. If they have Medicare, it's completely covered. If they have insurance, there's other insurance, there's a small copay. But the idea behind this is that the patient, instead of doing a home AMSR grid, looks into this device every day. And if something is change or something's changing based on the patient's responses, a notification is actually sent to the practitioner to call the patient to come in. So that's amazing. I think it's a fabulous way of monitoring these patients. They also actually have a home OCT program now for detection of choroidal neovascular membrane. So maybe patients that have already been treated, or we're checking for conversion to the wet form. So both of these are based on artificial intelligence. So I wanted to share with you just a quick case study because I think this is so fascinating for patients that have intermediate AMD. So this was a patient that came in. They had AMD for 3 years. They had a cataract in that right eye, so the vision was decreased. But what you'll notice here is that they had definitely some intermediate sized drusen. There's also this little hyperreflective foci here, which is a sign of pigmentary changes. So definitely had intermediate AMD. This patient was given this 4C home device, told to take an AREDS vitamin, instructed on everything proper that they should be doing. They were sent for cataract surgery and told to come back after for follow-up. They came back after cataract surgery. Vision was much better. The OCT findings looked stable. Patient was continuing with the 4C home. Then doctors alerted. They're alerted. I don't know. They started coming in 2019. They were alerted in 2021. You can see this light going off. Doctor gets an alert. Something has happened with the patient. We call the patient to come back, and this is what we see. The patient has developed a choroidal neovascular membrane. There's extensive drusen. There's pockets of fluid. There's an occult membrane here. There's hemorrhaging up here. So there's a lot of stuff going on here. Sent the patient off to retina, continued with 4C home in the left eye, and the patient is doing much better. So the idea here is that if you have a patient with intermediate AMD that has insurance, any kind of insurance, even if they don't, sign the patient up. It costs almost nothing for the patient. And this is a fantastic way, if they can't get into the office, to pick up on subtle changes. So, we're talking about, when do we need to refer? When do we not need to refer? Well, intermediate AMD doesn't need to be referred. There's nothing that's going to be done. However, if this machine alerts you that something has changed, then we know that this is automatically going to be a referral. Another thing that I wanted to talk about, because this is a really big hot topic for intermediate AMD, is something called photobiomodulation. So this is something that's brand new. I'm super, super excited about this. This is something that uses an intense, or I don't want to say intense, but a specific low-level light therapy to work on mitochondria, like Greg said before. What it does is this light kind of brings the mitochondria back to life, and it makes the mitochondria that was sick healthy again. And it's incredible because these are patients that have intermediate AMD. I'm going to show you a picture of the reversal in the changes that can happen with photobiomodulation. This is what the machine looks like. It's the first and only FDA approved machine. You can see that it's made by Lumathera. Super, super cool. Patients that have intermediate AMD 2030 to 2070, they cannot have any evidence of advanced disease. So the studies told us that after about 2 years, patients that were getting photobiomodulation improved by about 1 line of vision compared to those that were not receiving the treatment. They need about 3 sessions a week for 3 to 4 weeks for a total of 9 sessions. And they go about 4 months between treatments. So I'm hoping that this is something that optometrists are going to be able to do. It's non-invasive. It's almost like IPL that we do, but using this light therapy. And this is a picture that the company provided. This was before. I mean, look at the size of these massive drusenoid PEDs. I mean, this is a patient with significant intermediate AMD. And this was post photobiomodulation therapy. So I think there's amazing, amazing promise for this. And like I said, I hope that we'll be able to get to do this. And this is the photo of the patient. So, we talk about, and I'll talk about this in just a minute, but a lot of times we're worried that when we have drusen that goes away, that it actually is not a good thing. But in this particular case, this is a patient who showed some resorption of these drusen post PBM, and it was just a really great example. All right, so things to keep in mind with intermediate. We're going to go back to my patient now. The left eye. This was the eye that I blew. Okay, so left eye, I remember, had decreased vision. I don't remember what it was, 20/60, 20, whatever it was decreased. And I looked at the patient and I'm like, he's got some, kind of some funky color things going on here. He's got some drusen, but let's get an FAF because who knows? Turns out this patient had significant foveal sparing geographic atrophy. So remember that on FAF, when you have dark areas, that is loss of tissue, right? That is death. The white spots or the hyperfluorescent spots are areas that the RP is like running and trying to hold on to every breath that they have. And eventually that area will die as well. So it's like white precedes dark. So I was like, oh my God, I cannot believe this patient has so much geographic atrophy. I certainly could not appreciate it that well on the fundus image, but now that now I won't miss it because I know what I'm looking for. So this is GA. On OCT, what are you looking for? You're looking for areas. Remember, the definition of GA is where you have a loss of tissue at the RPE, right? So all this tissue is gone here. And so you end up getting something called choroidal hypertransmission, where you have the signal falling into the choroid here. You have what we call these little gull wings, which are areas where the sensory retina is collapsing down. You have substance. So why is this in a lecture on should I refer or not? I'll go into that in just a second because I want to talk about some other high risk things here, but we actually have some choices now for patients with GA. Remember reticular pseudodrusen as a very, very big risk factor. Remember, these go up past the photoreceptor integrity line. These are little normal drusen, and these are abnormal, not abnormal, but these are reticular pseudodrusen. Other things to look for, patients that might progress, remember to look for those hyperreflective foci, which are indicative of pigment dispersion or pigmentary changes that definitely put a patient into that intermediate category. Look at the size of these drusenoid PEDs. They're huge. Other things, look for the subsidence. I told you the gull wings, the choroidal hypertransmission. Those are all things that are going to eventually result in geographic atrophy. I should say choroidal transmission means there's GA. And this is what I talked about with the drusen before. Normally we look at this and we used to think, oh my God, I have a patient with these huge drusen. I bring them back and the drusen look like they went away. And oh my God, what are you doing, Mr. Jones? You look amazing. Well, this is not necessarily a good thing. We learn now that when drusen collapse, normally that means that geographic atrophy is going to form in those areas. So keep in mind that if you have a patient like this, certainly don't give them wrong information, because what we do know about this, unless they're having photobiomodulation, is most of the time when drusen collapse, it's definitely not a good thing. All right, so that being said, you can use fundus autofluorescence to help you to identify signs of geographic atrophy. That's what saved me on this case. I would recommend any patient that has drusen, get a photo, get fundus autofluorescence. I'm not going to go through the detail of this slide, but there are certain characteristics that put a patient more at risk for fast progression than others. So certainly get it because you'll at least be able to pick up on the GA.
Hey,
But
Julie, just remind everyone that whenever they're looking at an FAF, if you can go back to that,
yeah.
that FAF is very specific for looking at the RPE. If you can just kind of maybe just point that out.
Yeah. So remember that the way that FAF works is that we're looking at the amount of lipofuscin in the RPE. So we shine, or the machine shines a specific wavelength of light at the retina or at the RPE. And normally we're going to have a certain amount of what we call autofluorescence because everybody has lipofuscin in their retina or their RPE. When you have too much or too little lipofuscin, that is when the pattern on the FAF is going to change. So like I said before, if you have no lipofuscin, you're going to have dark areas. If you have a hyper metabolic or active RPE because it's working double hard because it's not healthy, you're going to see this brightness. So anything that has lipofuscin essentially should fluoresce. That's why the optic nerve and the blood vessels are dark. But yes, Greg, FAF is specifically for outer retinal disease, specifically looking for areas of RPE disease.
Yeah, and black is dead, so dead is dead, and then that hyper is kind of the struggling and kind of screaming for help, and then you can see kind of, I'm looking at that kind of unifocal, the second one over on the top row there, kind of in the center there. Yeah, black is dead, and then you have that little activity. It's kind of screaming for help. It's kind of the flares going up saying, "Hey, help me," and then you
Right.
can see kind of the rest of the normal retina-ish, if you want to say that, but it is kind of dead RPE versus struggling RPE.
Correct.
Hey, Julie, before you get too far, the first question came in about the 4C home
Mhm.
monitoring. How
Yeah.
many practices are actually using home monitoring devices? I'm not sure that you would know that.
Yeah, I mean, I don't have a specific number, but I will tell you that, I follow them on LinkedIn, and it's really exciting because every other day they post how this practice found a conversion. So there's quite a few practices out there using it. I would encourage, again, it's made by No Television. I would encourage anybody that doesn't have an account with them. It's like I said, it costs the patient almost no money. It doesn't cost you any money, so it's a no-brainer. It's like you don't have to buy the device, and all it can do is help the patient. And I find, I mean, I'm trying to do it on, as many patients as I can. I find that they prefer using it's like a video game. They have to line up targets. I actually just practiced it, played with it at Seco. And it's very easy to use. And they enjoy doing that more than a home answer grid, which I think sometimes they find confusing. They're not sure, what did I see the day before? So yes, I don't know the answer, Joe, but I would encourage anyone that doesn't have one to certainly look into it. It's one of my favorite things right now that I'm doing with GA with AMD.
I've
Yeah,
been working with
we're
them for
doing
about 4 or 5 years, and
Yeah.
I don't know the exact number, but they keep increasing. It keeps getting better coverage by insurance. That's the key. But I will echo, Jolie, you don't have to buy it. You're just prescribing it. You get a portal that's out there. I do it at my practice. And but you can log in and see if the patient is doing it and look at it. They'll give you a little web portal, and it's really cool whenever you do get an alert. I mean, not really cool for the patient, but you do get a few false, I guess, positives that are out there. And so, you might get an alert, which really isn't, but I can tell you the ones that I've been alerted on, most of the time it is a conversion and you're catching it early.
Yeah.
yeah, we've begun doing it in our office actually.
Yeah. I mean, to me, it's a no-brainer. It's been, so again, just to reiterate, for patients that have intermediate AMD, there's also the home OCT, but we're not using that one yet, but the 4C home, it's fantastic. So thank you for the questions on those. Anything else? I can keep going here. Let me go back
You're
to,
good.
okay. Let me just go back to where I was.
Yeah, it's kind of funny that we say photobiomodulation is catching on, and I just want to give some, I think everyone knows I've been doing some functional medicine. That's your functional medicine side. You're using light, you're stimulating the mitochondria, you're trying to move the debris out there, kind of like what we're doing with low light therapy, red light therapy on the face. That some people do red light therapy at home. They have kind of full units for themselves. But photobiomodulation's been around since like the 1990s. It's just finally getting some credibility, I guess, out there. It had credibility back then, but I guess it just takes long for us allopathic people to believe in kind of the functional side of things. So,
For sure. So just to reiterate, if you have a patient with early AMD, really, there's nothing to do. You recommend diet, exercise, cardiovascular health, UV. You might want to recommend a supplement. Intermediate, all those things. And now please think about introducing some of these AI home monitoring. But what I also want to talk about, I'm sure everyone at this point has heard about the new treatment options for geographic atrophy. But if you haven't, I wanted to give a brief overview, because it used to be that if you had GA, there was nothing you can do, right? If you had GA, it was like, man, you got the one that there's nothing we can do for. Now there are two treatments for geographic atrophy. So there's Syfovre and Izervay. These are intravitreal complement inhibitors. Couple of words to keep in mind. Number one, they are injections. They're not anti-VEGF. They are complement inhibitors, which I'll talk about in just a minute. And they do not reverse the disease, but they slow the progression of the disease. So our job is to identify the earliest signs of geographic atrophy. I mean, if I go back to this FAF slide, I would say that every single person on here would be able to find GA that looks like this, or that looks like this, or that looks like this. The ones that we want to find, we want to find all of them, but the ones that we want to find are the ones that are living right around the fovea, but maybe haven't affected vision yet. Because if we could inject, not us, but if those patients could receive intervention, the goal would be that they would outlive the disease, that this little spot would never get to the fovea. So that's the goal behind these therapies, is to try to preserve that sweet spot in the eye for as long as we can. So just to give you a really quick, nothing boring, but what is the complement system and why do these complement inhibitors work? You know, in the perfect world, our complement system is there to protect us. It's part of our immune response. But in geographic atrophy, there's overactivation of the complement system. And when you have overactivation, the membrane attack complex becomes activated, and that's when our tissue dies. So the idea here is that if we could slow down this complement system, then we would have better outcomes. So when you look at this pathway, and I'm not going to go through this, the complement pathway is a very, very long and arduous process or pathway. But the two medications each work on a different part of the complement pathway. So I'm going to talk first about Syfovre, which is made by Apellis. Syfovre works on C3. So again, the idea here is that we want to kind of X out or slow down this activation of C3. And just to go through some of the statistics, because I think they're really kind of, they're good. They're exciting. When you look at Syfovre, there were two main studies that were done, Oaks and Derby. This data was done through 2 years, and you can see in the Oaks, when patients were receiving this injection every other month, they have had an 18% reduction in growth rate of the GA. If they received the Syfovre every month, there was a 22% decline in the growth rate. In Derby, it was 17 and 18%. So it's worth something. You can see that they did something called the GALE, which was an extension study that went through 3 years. And what you're going to notice here is that the numbers keep getting better. So the idea here is that if we could get the patient to be committed to treatment, the longer they're on the medication, the better they seem to do. 35% drop monthly, 24% drop every other month. There were side effects, as in any medication, there's going to be side effects. You know, some of the ones to keep in mind are the ones that have come to our attention that always tend to scare people. The neovascularization, whereas neovascular AMD. So in monthly injections, it was 12%. Every other month, 7% versus the sham, which is 3%. And there were, you know, a couple of cases of retinal vasculitis, which I'm sure that, you know, everyone's heard about, but they have gotten control over that. So, you know, as a whole, these medications are safe. They're learning to, you know, if they do develop macular neovascularization, they're being treated. And I guess the question really becomes, you know, does the benefit outweigh the risk? And certainly if we're trying to preserve vision, in my opinion, it does. The other medication is Izervay by Astellas, which works on C5. Numbers, again, awesome here. So the GATHER trials were the ones that looked at the safety, I mean, at the efficacy of this medication. You can see here that through 1 year, there was a 35% reduction in growth rate in GATHER1 and an 18% reduction in GATHER2. Looking at the safety data, there were no cases of retinal vasculitis. Again, a little bit more of an increase in the choroidal neovascularization, which we saw also with Syfovre. 1 case of IOI, you know, these are, you know, the pretty safe medication here. So certainly my recommendation, the way that I deal with these cases is I try to at least introduce the patient to a retina specialist, whether or not they're going to treat, that's not my call, but I like to at least get the conversation going so that when they do decide that they want to treat, that the patient feels comfortable with the retina specialist and, you know, they're ready to start the journey together. So our goal, and this is what we don't want to happen, is that this doesn't happen, right? The goal is that when I first saw the patient, which was before these medications were introduced, that would have been, in my opinion, at the appropriate time to refer, because this patient did not have foveal involvement. You can see there's a little wedge here. That's clear. And then over the course of 3 years, look what happened to him. He went from 20/40 to counting fingers because the fovea became involved. And so if we would have intervened and if he would have received an intravitreal complement inhibitor, perhaps we could have slowed down the progression. And so it would not have, you know, gone into the fovea. And just one statistic that I think is really interesting is it takes about 2.5 years for an extrafoveal lesion to become foveally involved. So if this patient would have started on treatment within this 3-year period of time, perhaps the fovea would have remained spared. So it's just something to keep in mind. I would hope that our goal, at least, is that optometrists will be able to pick up on these lesions and become comfortable referring GA.
Hey, Jolie, go back to that one slide there and that first one there that you look at that color photo where it's 2040 and you can see that kind of that foveal is still in place there.
Yeah.
That's where I want to point out to the audience. That's when we want to refer. And like you said, the retinologist will decide if they're going to inject or not inject, but this is the time where we want to send them. I do want to feed off of with these medications, these C3, C5 inhibitors. And I want everyone to remember, whether it's dry or wet, is that it's more of an autoimmune disease. And if you've ever done any genetic testing and you look at the genetic test, it says ARMS, complement factor CFH, complement factor H, and then complement factor 3. Remember, these are genetic SNPs. And if you have those genetic SNPs, it puts you at high risk. I'm going to keep ARMS out of it because that's more metabolism. But your complement factor H and your complement factor 3 bridle the immune system, right? So Julie just talked that in a perfect way that our immune system should turn on, should turn off, and that's in a healthy immune system. But when you have a genetic SNP, complement factor H, complement factor 3, that's what puts the brakes on a normal immune system. Now you have the genetic SNPs, the brakes don't work. So now you get damage, it doesn't turn off, and now you're seeing this geographic atrophy. That's where these complement factor inhibitors 3 and 5 can plug in, slowing down that immune system that now cannot slow down. So that's kind of tying all that genetics, this picture, that first picture that you're showing there in that upper left-hand corner there, that's the one you want to refer. And then hopefully the patient gets treated so they don't go down that 3-year pathway there. And that's where these medications can come into play. Now, it is treatment for life. So if you start injecting, now who knows what new will come out over the years, but maybe we can hold them into something there until something new comes out. But I just wanted to kind of tie that all
Yeah.
together.
Sure. And, I find, Greg, that patients that have a really strong family history and they have grandparents or parents that went blind are extremely motivated, and not offering them the option, I feel like, is doing them a disservice. So at least having the conversation and letting them make the decision with the retina specialist, I feel, is the appropriate way to go. That's, that's where optometrists do. I think that's where we're successful, is in our conversations. So I just wanted to talk about that because this is something that we should consider referring. Okay, so here's the poll question. I'll read it. Which of the following is true regarding management of GA, secondary AMD? Lifestyle modification, smoking cessation, ARED supplement are the only treatment options for these patients. Syfovre and Izervay are intravitreal anti-VEGF agents approved for slowing the progression of GA. Syfovre and Izervay are intravitreal complement inhibitor agents approved for slowing the progression of GA. And Syfovre and Izervay are intravitreal complement inhibitor agents approved for reversing signs of GA.
So the calling question is open and questions or answers are rolling in.
Nothing in the chat. We're all caught up.
I'll just throw out there while people are answering this, if I could give one word of wisdom, and I think I've already said this, but I'll say again, if you have FAF, it takes one extra second to snap it on every patient that has AMD, because you will be amazed at the stuff that I miss stuff all the time that is highlighted on that technology. So it'll only make you a better doctor by using this multimodal imaging.
And that's the key. I mean, that's why we try and point out, that's why we do the education here. We bring on great speakers like you, Jolie, so that we can, remind people that FAF is looking at the RPE. Now you're kind of understanding what's happening. And then you have your B scan OCTs, and we have A scan OCTs now. And then we have the color photography. I think we got a little bit away from that because we all kind of went to these wide field imaging, and maybe it loses a little resolution. You pick up the big stuff. But I can tell you right now, I'm happy that I have kind of a dual camera system in the practice. With the advancements and treatments that are out there, we need to be able to have this multimodal, which is color photography, fundus autofluorescence, and OCT, which could be dual in B scan and OCTA.
And if we have one more second, I'll throw one more thing out there. For those of you that have OCT, if you can picture while you're taking an OCT, there's always that black and white image right next to the OCT. That's actually called NIR. And that's actually something that's awesome at picking up a GA also. It looks reverse from FAF. In other words, GA is actually going to be white. because it has better penetrance into the RPE. But so if you don't have any of these modalities, but you have an OCT, you actually have another great way of looking for GA if you look at that black and white image that you're getting right next to the OCT, the B scan.
So 83% went with C, and then we have just kind of a scattering of 2%, 9%, and 6% for A, B, and D. So C was 83%. So would you like to give the answer?
That's it. Okay, so let's keep going here. Go back to a little bit of vitreous stuff. So this is a 75-year-old female with a slowly progressive decrease in vision in the left eye with a spot in her central vision. She was pseudophakic, and look at the vision in that left eye. It's 2400. So automatically you know that this is going to be something pretty significant. And just look at, I mean, what a amazing photo, right? So you can see here that we're visualizing down to RPE here. Whenever you see maroon like this, you're visualizing down to RPE. You can see that there's this like cuff of edema or cuff of fluid where this lip of retina is elevated around. This is a full thickness macular hole. This is a picture of a full thickness macular hole. Remember that we're looking at loss of tissue from ILM down to RP. I will emphasize how important it is when you have OCT to dynamically move through your images. Don't just look at one cut, because what you'll find sometimes, especially with macular holes, is that one cut might look like it's actually attached. And then as you scroll through, you'll see that there's that complete detachment. Remember that the last point of detachment of the vitreous is over the optic nerve. And this is a little operculum here that you can see floating above. So just to go through super quickly here, when you're classifying full thickness macular holes, the OCT-based system to me is so much easier. We all learned the GAS criteria when I was in school, and I couldn't tell you right now what it was. I can't memorize. But using the OCT-based system, we're looking at the smallest aperture on the OCT. So when you're, and I'll give you an example, but these are the measurements here. A small is going to be less than or equal to 250 microns, medium 250 to 400, and large greater than 400. So when you're looking at the OCT, you find your smallest point of separation. That's what you're measuring. If that smallest point of separation is less than 250, that is a small full thickness hole. These do very, very well. Vision's probably going to be relatively good, and patients have a really good success rate with vitrectomy. If you look at that small separation, it's 250 to 400, you're looking at medium. And remember that the larger these holes get, the probability of having a really good outcome goes down. And then here's an example of a large. But the summary point with all full thickness macular holes, and I'll get to that slide, is every single one of them needs to be referred out. You are not holding on to a full thickness macular hole, even, at least in my opinion, even if a patient comes in that has had one for many, many years, I still recommend a referral. I think you owe it to the patient. There's so many great new procedures. We talked about the inverted ILM flap. There's so many things that might be able to be done that I think you at least should recommend it. When you're looking at classification, I told you small, medium, large. There's actually extra large and extra, extra large now too. But the other thing is, what's the vitreous doing? What's the vitreous behavior? If you can still see the vitreous there, we call it primary. If we don't have vitreous involvement, it's called secondary. So, if I were to categorize this one on top, it's likely a primary, medium, full thickness macular hole, and probably on the bottom, a secondary medium, again, based on that smallest aperture. So for management, refer these out. Okay, surgeries, pars plana vitrectomy, ILM peel, maybe one of those ILM inverted flaps. All right, here's our next poll question. Which of the following is not true regarding full thickness macular holes? Since little can be done for them, they can be monitored regularly by an optometrist. All of them should be referred. The outcome of the surgical intervention depends on the size of the hole, and vitrectomy with ILM peel is the gold standard of treatment.
Joe, any questions in the chat box?
Nope, we're all caught up.
That means we're doing such a good job, right? Nobody has, or either that or everyone's sleeping.
No, they're picking up what you're putting down.
Greg, what's the statistic now? I don't know if you know how many optometrists out there have OCTs. Do you know the new statistic?
I don't, but we do some OCT, questions or multimodal talks, and I'll ask how many have photography and so on and so forth. And, I think it's kind of the 80% is probably a good number, say plus or minus a little bit. OCTA is starting to creep up,
Yeah.
that's out there, which is kind of neat. And it'd be kind of neat now that there's a code that pays for it. But I think it's about 80%. When we do our live meetings and you get the old raise the hand, and then when we do these, I'll ask how many people have OCT, OCTA combination, or
Mhm.
or anterior segment. It seems to be about 80. But that's OEC polling.
Yeah.
So
It's a well-educated audience.
there we go. So, all right, Julie, this one's a little bit all over the place. We have 44% with A. You might want to go through the answer and go over. So 44 with A, 32 with B, 20 with C, and 4% just went with D. So D seems to be out of the question, but you can go through them maybe since this one's a little bit more scattered.
Okay, so, I said which one is not true. So really what I was looking for is that the first one is I think what I wanted was not true. Since little can be done, they can be monitored. So in some cases, yeah, little can be done. However, in my opinion, and if you look at guidelines, it's recommended that patients that have full thickness macular holes be referred to a retina specialist. Now, there could be cases where a patient comes in and they've had one for 40 years. They know they've had it, and likely the outcome, if you sent them, is not going to be, not going to make a difference. But I at least offer it to the patient. My opinion, do you want to go see a retina specialist? Some of them say they've already gone. So I think all full thickness macular should be referred. The outcome of the surgical intervention does depend on the size of the hole. I said that before. Smaller holes tend to have a better outcome than larger, and vitrectomy with ILM peel is the gold standard of treatment. So the one that I feel is not the best answer is A. And again, I said at the very beginning of this talk, there could be differing opinions on certain things, but that's where I go with this. Okay, so let's move on to the next one. 35-year-old male, he can't see out of his right eye for a month. He thought it would go away on its own. He's had flashes and floaters, which have subsided in that right eye. He's 2400 in the right eye, 20/20 in his left. So here is the photo. We've all seen these patients on Fridays at 5, right? So I think everyone can see here that this patient has a macular, what looks macular off RD. What I will say here, and I should have included in here, is if you're ever not sure, obviously visual acuity is extremely helpful. Get an OCT. Remember that the definition of a retinal detachment is separation of the neurosensory retina or the sensory retina from the RPE. So if you're trying to figure out if the macula is on or off, get an OCT right through the macula. You'll be able to see if there's a complete separation. So this one's a macular off RD. And this one is a macula on RD. So beautiful images of two very different scenarios here, neither of which we want to have in our office. So from a management perspective, we think about, what are we going to do with these patients? What's the urgency of referral here? Just to review, just for 1 second here, 3 key terms. I thought this slide was so cute. When you're talking about retinal detachments, there's 3 varieties. Rhegmatogenous is the kind that's associated with a retinal break, tear, hole. Traction is what we see with proliferative diseases like diabetes, sickle cell, Coats, actually not Coats, diabetes, sickle cell. I'm trying to think the proliferative vitreoretinopathies. Serous is when you have a tumor, when you have coats, when you have exudation, something is lifting up the retina from the RP, but it's a different kind of process. There's some kind of fluid or material there that's causing the separation. So just a review of the 3 different types there. Okay, so the easy one is macula on. If you have macula on, patient likely has good vision. You're getting that out of your office stat. We're super lucky in South Florida to have Bascom Palmer. So this is going to Bascom Palmer yesterday. If you live in a place where it's a little bit harder I could ask Joe and Greg, if you live somewhere where you don't have an eye hospital, although Greg, you're down from Will's Eye, right?
I'm close to the Pittsburgh, but
Oh,
I have retinologists that do come to my town. So
okay. So yeah, these are, and Joe, you must have a retina guy that you call up, but these are, actually, Joe, you work in a retina practice, don't you?
No, I work in a medical surgical practice and we have retina.
Okay.
But it all comes down to something like that is who's on call, because we have several retinal specialists who don't work with us, but will take call for us, and they are our backup. And generally speaking, it's a same day or next day when we reach out. They're all very good about it.
Okay.
Julie, do me a favor, go back to your images where you had the one where the macula was on. That one right there. Remind everyone the size. That's the macula. Oh, there we go. Perfect. I want to remind everyone, remember the macula, because I do this in a polling question and it's always 50-50. The people think the macula is actually the fovea.
Right.
But
So,
remember that the disc out there, audience, the disc is 1.5 millimeters. Looks like this one could be a little smaller, but that one's 1.5. So, we're going to need about three of those to make 5 millimeters. So point out the macula here, Jolie. Show the macula, how big the macula is with there you go, with your pointer. That's the macula. So it's not fovea on or off, it's macula off or on. So if that macula is on, and remember the macula is big and it's still on, you want that immediate referral that's out there. So this macula off one, okay, you have a little bit of time, means they don't have to be seen that day. They'll probably see it that day, but they won't have surgery the next day. This one here, macula off, they're going to still see it that day. They just might not rush them into surgery that day or the next day. So,
right.
but
So Greg summarized this slide right here. The name of the game here with any RD is the sooner the better, right? We know that. But if the macula is off, they say ideally within 48 to 72 hours is when you want to get them in. But if you call up, I mean, and you guys all know this, you call up the retina specialist, the first thing that the secretary or the front desk asks you is the macula on or off, right? They're well trained. They know exactly what to do. So sooner the better, but ideally within 48 to 72 hours. Okay, so here's our next polling question. Regmatogenous retinal detachment may be macular on, or I don't know, I should put macula, not macular, macula on or non-macular involving, which is true. Macular involving RDs are an ocular emergency and should be referred that day. All regmatogenous RDs need to be seen by retina that day. Myopes are at a greater risk of developing regmatogenous RD than hyperopes because of shorter axial length. Patients with regmatogenous RD will always experience flashes and floaters.
And while this polling question is rolling in, the polling question is open. If you have that macula on and you make the call and they're going to see them that day, and it might not be for maybe like an hour, like I'll send them over, but it's 1 o'clock now. I'll see them at 2:30 or 2. Make sure that if they stop or go home that they don't eat.
Yes.
Because stop at Whataburger, stop at McDonald's, stop at home, grab a ham sandwich, because depending on what they ate and the last time they ate, they can go maybe in and get some anesthesia and have the repair done. So remind them, if they get an appointment that day, don't stop, don't eat, and go get a water or something, because they might want to do surgery sooner rather than later, and it's all based on the anesthesia.
Yeah, interesting, Greg. Unfortunately, what I've seen, you're right about it, is that ship is usually sailed. They've already eaten that day. But what I find in our practice and other practices, they'll do a gas bubble injection to buy them time, because sometimes it's not so much the eating, it's they don't have OR time. They can't get into the OR. And I actually do know that one of the practices that we work with, they have a nurse practitioner do the gas bubble injection.
Wow.
All right. Good points. Good. Thank you. That's awesome. Yep. And the polling question, we have 68% going 65, just went down to A, and then 22% doing B, going right down the line, 11% saying C, and 3% going to D. So do you want to go over that a little bit?
Yeah, so remember, we just said this, that if you have a macula involving RD, we want to get them to the retina specialist ASAP, okay, as soon as possible. All regmatogenous RDs, we just said, I mean, do they have to be, if it's macula off already, that day is not necessarily necessary. This next one was intended to get people, but remember that myopes have a longer axial length than hyperopes, so that was a trick question. And then sometimes patients are asymptomatic. They're not always going to have flash sun floaters. Remember to look in the vitreous for a Schaefer sign. That's always helpful. Greg, a funny story, Joe, not a funny story. My dad this summer experienced a positive Seidel. He was poked in the eye with an agave plant and went down to Bascom. And, I took him down there. My mom said before we left, Eric, take a bagel with you, a piece of bread, whatever. You're going to be there all day waiting. So of course he ate in the car and we're driving down there and we get there and they wanted to take him right up to the OR because he had an open globe. Bottom line is, he waited 8 hours. We sat there. I'm like, my mom was killing herself because she wanted my dad to eat something. So excellent point. It was a long day and it didn't have to be that long. So anyway, thank you for sharing that clinical
Pass it
pearl.
along to dad that agave fermented is better going down your throat rather than going into the eyes.
Correct.
Hey, Julie, a question came. It wasn't a recent study showing MAC off still needs to be operated on within 5 days.
Yeah, I mean, that's what we said here. 48, 72 hours was ideal.
Yep.
Yeah. Okay, so let's go to the next one here. This was a 29-year-old male. He was a -450 myope with long-standing floaters, no flashes, 20/20 in both eyes. So you can see here, if you look very carefully, I know it's kind of sometimes hard to see, but hopefully you can see there's lattice. You can see there's some atrophic holes here. Down here, some big atrophic holes. So remember that atrophic holes happen because of thinning. So I like to think about like a soccer, like a tennis sock. You take it and you're pulling the sock and you get these holes because you're thinning out the retina. Okay, so it's not happening because of vitreoretinal traction. There's no adhesion to the vitreous. It's associated usually with lattice because these are areas of thinning. So this was a 450 myope, this patient. He was, let me go back and remind myself here, was he symptomatic? Let me just see here. He had long-standing floaters. Okay, so the question to ask yourself here, these are things we see every single day. Do I need to be referring these patients? I mean, the first thing I always do is I look at the vitreous. I always looking to see if I can see pigment. The problem is a lot of my patients are older. They're pseudophakic and they're going to have pigment in the vitreous just as a result of having surgery. So it's not always a no-brainer. But if the patient is asymptomatic, and the majority of the time we find these on, routine exam, patient's got a couple of holes, I would say monitor them. If you want to watch them a little more closely initially and then spread out the follow-ups, that's fine. It's always okay to refer. But there's a couple of things here to keep in mind for referral. If a patient has, okay, so the ones that are, these are the ones that don't have to be referred. An atrophic round hole within lattice, asymptomatic, you can watch. Minimal subretinal fluid without progression. Now, I would argue, and this is from the guidelines, but I would argue that if a patient has any subretinal fluid, anything around the hole, I would refer. Okay. But they say here minimal subretinal fluid without progression or a lack of PVD. And when I first read this, like, why a lack of PVD? Well, the idea here is that if you've had a PVD, it messes up the relationship between the vitreous and the retina because once that vitreous detaches, there's a weakening between the interface. So if they still have their vitreous attached, it's almost like there's still some integrity between the two, the posterior hyaloid and the ILM. Those don't require treatment. If a patient is symptomatic, if they have a cuff of edema, if you see pigment in the vitreous, obviously, these are patients that you want to refer out. So, and I wrote down here, some studies suggest that prophylactic laser pexy may be considered for eyes with retinal holes when there are active symptoms. Again, if there is evidence of subretinal fluid. What about the other eye? If the patient has a retinal detachment or a history of retinal disease in the other eye, certainly refer. But I know that these are cases we see all the time, and we're not referring atrophic holes, if they're uneventful. Something else that I always like to do, I don't know how you guys feel about using the gonio lens, using the peripheral mirror on the gonio lens to view peripheral retina. I think it's a really, really good tool if you're looking at a hole in lattice or just a hole in general, and you're trying to figure out if there's fluid around it, if there is a lip, if there's something that you should be concerned about. I personally feel more comfortable doing a gonio exam than doing scleral depression. I think I just get a better view. I'm able to hold it there. The patient doesn't blink. So anyway, use that. That can be very, very helpful to look at these atrophic lesions and see if you think it's worthwhile to refer.
Yeah, my preference is to do off axis 90, right? So if they dilate well, try and do 90, but then sometimes it's pretty far out there. Use that thumbnail mirror on that Goldman lens. You can get a really good binocular view. And, my third would be my least favorite is to go for that scleral depression. I'm not good at it. I mean, I'm decent at it. But I'm better at off axis 90 and I'm better at throwing a lens on there and kind of having them look towards everything and moving it. And then if I have to, I go to depression. But
Yeah.
that's kind of the way I go for it.
Yeah. And I agree, Greg. I tell the students in the clinic, I'm like, unless you feel 100% confident in your scleral depression, and you're going to make a clinical decision based on what you're doing, then use other modalities that you feel more comfortable with, right? Because you're basing your decision on whether or not you're going to hold or refer maybe on that, on doing that skill. Okay, so here's another one, talking about these little peripheral, what a fabulous photo here of this. Hopefully you can see this little abnormality here on the bottom here. So this one is an operculated retinal hole. So remember that an operculated retinal hole, they look similar to atrophic holes, but the difference is that they have this little free-floating operculum sitting above the hole. And the difference here is that there was at some point some anomalous relationship here between the vitreous and the retina. So unlike an atrophic hole, there's almost like this suspension or this little vitreous kind of plug that's sitting between the hole and this little piece of operculated tissue there. And if you're wondering why this little operculum isn't the same size of the hole, it's because think about it, it's dead tissue. It doesn't have a vascular source. It doesn't have a retinal blood supply to it anymore. So it shrinks away. Okay. So, we see these all the time, percolated holes for the most part are pretty benign. Do we need to refer them? I'll go back to the same thing before, when patients first start getting the operculated hole, they're probably going to be symptomatic because there is a vitreoretinal relationship there. But once that operculum releases and it's just kind of hanging there and suspended, they usually become asymptomatic. And at that point, I would say that treatment is likely not necessary. There's a very small percentage of them, 1% of asymptomatic operculated holes will develop into RDs. So, if you want to refer them, if you're worried about it, if you can always refer, but they're really very, very benign. And treatment is, again, considered in certain situations if you have a very large one. And I think I showed you, like if you had, just to go back here to this picture here, if one of these back here, like these are huge holes down here, this might be somebody that you want to refer if there's no operculum or not, because the size of it's massive. So there's a lot of things that are going to help you to
Pause
determine.
right there. Go
Yes.
ahead. Keep talking, but pause that picture.
I was just going to say, there's a lot of things it's not cookie cutter with retina. What you do for one person might be very different than what you do for somebody else based on the size, location, other eye, things like that.
And I agree. I mean, it's all different on every retinologist. My retinologist would say, "Hey, this patient was asymptomatic. This is inferior. They're not going to treat it." But what I wanted you to pause there for, I could throw a gonio on there. I could do, scleral indentation, blah blah blah. That might be a little bit too inward to do that. But I can look at with a 90. But I'm going to image that with my line on my OCT,
Right.
and I'm going to see how much fluid there is in there. And
Great
then when
point.
I bring them back, I really can, oh yeah, I can look with a 90 and so on and so forth. But I'm going to run another OCT image. That one's in close enough that a technician, a good technician, a skilled technician could get out there with one of your last raster lines or a single line and kind of cut through that in different ways and see the fluid that's under there and then bring them back. And then if you want to send that off to the retinologist and say, look, here was the fluid back, 3 months ago. Here's the fluid now. Do you want to treat this?
Right. And I can't wait for the day that these OCTs, I mean, I know there is a device out there that does peripheral OCTs, but I can't wait to get my hands on one of these devices because I rely so much on my OCT. So another great point.
Julie, it looks like we're getting close to our time. I got a few questions in here.
Okay.
One question, I think it's maybe the only question. Uh, Patient with 20/40 vision, fovea on, but RD is the outer edge of the macula per OCT. Is that considered macula on or macula off?
I would always take the side of caution and say macula on. I mean, if it's encroaching on the macula, you guys all know this, it could happen so quickly that the thing just spreads right over. So if you're in that area, and Greg talked, about disc diameters, if you're in that area, treat it as macula on. You'll save yourself, I think, legally if anything happened. It's always better to, in my opinion, to err on the side of caution.
Yeah, I mean,
The,
my sense here is the fact that there's 20/40 vision. There's got to be a reason for that, and most likely there is fluid seeping underneath. And in a reasonable area, like I said, we have a number of retinal people that we affiliate with in our practice. They help us out, they take overflow, they go on call, regardless of what it is. I mean, they will get the patient in. I'm going to say 77% of the time, they're going to get the patient in for me on the same day, even if it means them waiting a while to get, them staying around. And other than that, they'll get them in really the next day. So macula on, macula off. It's probably just best to get them in the hands of the person who's going to be doing it.
Agreed.
the key comes down, is that again, as we said earlier, are they going to do surgery within that 24-hour time period ish, or are they going to be able to wait that 5 days, as our colleague pointed out, or are they going to do they have the OR time that comes into play? Are they going to get a gas bubble? The key is that if you're not have an experienced office, you yourself and the person that's working at the retinologist, and you call up and nothing's being conveyed, and they say, okay, we'll see him in 2 weeks, that's not good.
Right.
Because we're the captain of the ship. This is where you want to be able to say, can I get the patient in today? Or I'll talk to the doc, or who can I talk to? The key is we just want to point out the urgency. The literature says that if it's on, they're going to have surgery within 24 hours. If it's off, they're going to have surgery within that 5 days or within that 48 to 72 hours. But it's just depending on the urgency. You just want to be able to get the correct diagnosis. But my point is, remember, the macula is bigger than we think. But even if it's encroaching on it, you're still going to get them, as Joe said.
I think a quick side question, and it probably involves the one you have there. They mentioned large CD ratio. Are you concerned? I'm going to say that's not that. That's in the lecture.
This is not a glaucoma lecture.
Mhm.
No, the answer is we're talking about referral or not. We'll refer to Joe.
And somebody
Yeah.
also makes a comment about a retinal specialist. Does scleral depression with the gonial 3-mirror lens? Has his staff hold the Goldman lens on and does the scleral indentation?
Oh my
Comment
God.
was it seems to work pretty well.
That's a talented person.
That is, yeah, can be done. So, any other questions, Joe?
No, I think we're all good.
All right. So, Julie, we have about a minute or two. Is there any fast? I know we kind of slowed you down a little bit with the comments, but this is what the audience likes, kind of more the podcast, the questions, kind of instead of having to kind of, just speak into a computer screen. Is there any final comments or any cases you want to go through?
No, I mean, I can just, say quickly, there was a CSR case here. I think we all know a CSR. When you guys get CSR, give it about 2-3 months. If you aren't seeing signs of resolution or if things are getting worse, those are cases we want to refer. I'm trying to think what else I had in there. I had a commotio retinae case. I don't know if any of you have ever seen commotio retinae, which is a traumatic retinal, I don't know what to call it, disease, but where you get disease of the outer retina, photoreceptors are damaged. Commotio retinae looks really scary when you see it, but it actually is a self-resolving condition, I was thinking to myself, if this walked into my office and I did have one, I referred it out, even though they say, oh yeah, commotio retinae is just gonna go away. Have you guys had one of those, Greg, Joe? Ever
Yeah,
had
I just had a bilateral case. There's an auto accident. She got thrown from the front seat to the back seat.
Wow.
Came in with horrible ecchymosis, and you can actually see the hyperreflectivity, almost like rain coming down right in the macular area. And her vision was diminished in each eye. And then when I saw her on follow-up about a week later. The commotio on OCT had resolved, but the photoreceptor lines were damaged.
Yeah. Yeah.
And I told her that there's nothing we can do, and she got very very frustrated with me and thought I was FOS and left. And then I got a message, can you send all her information to this retinal specialist in the area? And I did. I sent the OCT, and apparently he refused to see her. He said, look, he's right.
Wow.
There's nothing we can do.
Yeah.
And she came back and she thanked me for that, for doing that and saving her the issues of going to see him. And she said, I just couldn't believe there's nothing we can do. And one eye actually improved a bit, but the other is still sitting at about 20/60.
And
I
Joe,
read.
little did she know that's right when you had that colonoscopy. So it wasn't that you weren't that FOS. So.
Mhm.
Oh my. Oh boy, you guys are funny.
So Julie, I think the comments in there are going to be great. I think
Mhm.
when we do the survey here, the survey is open, and we didn't get through everything. But Joe always likes to say, the Rolling Stones never plays their whole songs; they never get through their whole list. But that always sets us up for a reason to bring you back. So hopefully you enjoyed it tonight. I'm going to have you stop
You guys are
sharing.
great
If
hosts. You're a lot of fun.
So here we go. So everyone, you'll see that instead of it saying glaucoma case, it will say to refer or not. But you'll see that the little red dot is up. And if you click on that right now, you can start that survey. If you haven't already, those who are, been here and frequent flyers knew what that little red dot means. That means you can start taking that survey. And with that, Joe, I'm gonna have you look one more time to make sure that there's no other questions.
No, no, you're just getting some thank yous.
There you go. So this is what makes it synchronous virtual. You're live, you're interacting with Joe, myself, and our expert speaker tonight here, Dr. Jolie Rodman. Jolie, I want to thank you for refer this, not that, retinal decision making. I think everyone they go to clinic the next day, well, hopefully it's tomorrow, will be better off seeing these cases that you covered.
Thanks, guys. Have a good night.
Good
Thanks,
night.
Jolie.